Welcome back. Happy Sunday. I'm Dr. G. So, every diabetic foot ulcer tells its own story, like legitimately, they can speak to you. And it's not just a medical story, it's a timeline, it's a crime scene, it's a chain of events. My mind's kind of thinking like that because I've been doing a Netflix documentary build. And fact of the matter is, I did not know how bizarre people can be. That is crazy. Especially the one called Fred and Rose West. That's a really good one. The Mariah girl story, that was really interesting as well. I was absolutely shocked at the end. I was like, wow. But thank God for people who are good at their job and they're able to detect and figure it out. And yeah, I love people who are really good detectives. Like they actually care and they want to figure it out instead of just sitting by and just like letting anything happen. Thank God for people who are, like, really good at their jobs. They can figure it out, they hone in, like, the way they figure certain things out are so interesting, I find that. But that's also how it has to do with wound care. So, like I said, every diabetic foot tells its own story, and that is absolutely the truth, because by the time we get to see the diabetic foot ulcer, you're no longer looking at the beginning of the problem. Usually it's at very end, okay, because of the peripheral neuropathy, but we're usually looking at the aftermath. But that's why it's such an important thing. Prevention is better than cure, checking your feet every day, routine follow-up visits with your podiatrist, things like that, okay? So today we're gonna do a little something different. We're not gonna be treating wounds, we're gonna be investigating it. We're gonna be doing some diabetic foot forensics, okay? Because every ulcer is evidence, every tissue is a witness. So we're not just finding wounds, they actually arrive, like I said, really late to us. So because, everyone has a timeline, the timeline is actually quite visible by its characteristics, and most already tell you a story about what happened. So you're like sitting down trying to figure out this wound, and you're like, what happened to you? So, what is forensic wound care? So, forensic medicine is all about reconstructing what happened before the clinician arrived, like what happened before all of this presented in your clinic. So, in a diabetic foot ulcer, right? We start asking, when did this breakdown start? What forces acted on this foot? Was there infection a primary or secondary driver of this wound? Was ischemia sudden or progressive? Did neuropathy mask repeated trauma? And like I said, with a diabetic foot ulcer, it is not a single event. It is a series of failures layered over time. So, mechanical failures like pressure, neurological failures like loss of sensation, vascular failures like ischemia, immune failure like infection control. So the wound is not random. It actually is a predictable history timeline in the tissue. So your wound literally is its own timeline. So let's break it down in a forensic. Stage one is usually starts with a silent injury, repetitive pressure, micro trauma, callus formation begins. Usually these patients do not feel pain due to neuropathy and it goes as an unnoticed incident. So how do we estimate the timing of a wound? There's no single clock. Oh, I wish I would have a wound clock. Yeah, a wound clock that can triangulate the patterns of a wound. So key factors are when we're trying to figure out the timing of a wound is edge characteristics, the tissue type, right? Saying like, is the tissue fresh or red or is it dull, pale or necrotic? Callus formation, exudate type, odor, depth, and undermining. So we would have to categorize the wound. Is this a acute wound or is this a chronic wound, right? So acute means days or weeks, what in our term. So acute means the edges are probably going to be cleaner. There's going to be minimal callus formation. Most likely, it will show red granular tissue, and it will be a sudden onset history. But if the wound is chronic, it'd be like weeks or months, right? There'll be a thick calloused edge. Sometimes there is something called epibole, the rolled borders. The tissue will be mixed. So it would be mixed with slough and necrotic tissue, and then it would be in a recurrent location. So chronicity equals repeated cycles of damage plus failed healing. Next is our structural breakdown. So you have to remember skin thickens and then cracks beneath the callus. That's why I try to get patients to understand it's not that this is not just the callus. And that's why we have to debride the callus because the skin cracks underneath it. You can also have a subdermal tissue damage that begins, as well as fluid shifts behind the pressure points. And this causes an internal collapse phase. So our structural breakdown of the wound is one of the hidden phases before the ulcer opens or reopens. So pathophysiology is this repetitive pressure can cause ischemia as well as reperfusion injury, shear forces, which are separating the tissue layers, microvascular damage, which is usually accompanied when patients have diabetes mellitus, as well as neuropathy, which is repetitive continued loading despite the injury because the patients do not have the protective sensation to stop loading on that area. And so what's going to happen underneath the skin, there's going to be a subdermal hemorrhage, which we see will be this dark red staining underneath the skin, right? Fat pad displacement, collagen breakdown, fluid accumulation, and this is creating a pre-ulcerative cavity. So when we identifying that, the callus with the dark, discolored underneath, soft and boggy feel, pain may be absent due to peripheral neuropathy, warmth, and subtle swelling. If you can only see a callus, you may be missing an entire wound that has not declared itself as yet, and that's why we have to debride, and that's even why we debride even when the wound let's say the wound finally healed, right? And there's a tiny little bit of callus. People might be upset and be like, "Oh, I don't want you to cut it again. Are you gonna make me bleed?" We have to make sure this isn't a wound again. That's the whole point. We cut if you fully debride, right, and there is nice, healthy, full epithelialized skin with no like breakage down, maceration, or anything like that, that's a fully healed wound. But sometimes wounds like to say they're fully healed when they're not, right? And they would just have this nice layer of slightly epithelialized skin over it. But if you fully debride, it's still a little bit of a wound underneath it. And that's how it can become something dangerous because everybody will be like, oh, it's fully healed, but it's not. Okay. That's why you have to make sure all the callus is removed, okay? We're not asking you to open it, make a new wound, but you have to make sure that this wound is not masking underneath it, okay? Now, the open skin, when the skin breaks down, that's an open lesion. Skin breaking down, exudate appears. Also, what happens is the beginning of bacterial colonization, and this scene becomes visible. This is a visible scene. Next, we have to think about infection or ischemia divergence. So now the wound has to choose a path. The wound has to choose a path if it wants to be infection dominant pathway and cause things like cellulitis, abscess formation, or osteomyelitis, or is this woman wants to be ischemic? If it's ischemic, going through the ischemic pathway, it'll become necrotic or even have dry gangrene. And a lot of times we see the mixed pathway, the infection and ischemic pathway, and that causes rapid deterioration, okay? And that's why our outcomes may vary depending on how the wound wants to diverge dramatically. So in an infection dominant wound, there's going to be rapid bacterial proliferation, spreading erythema that can lead to cellulitis, possible abscess formation, and possible progression to osteomyelitis. And hallmarks are warmth, purulence, systemic signs like fever, leukocytosis. And, the threat is not the lack of blood. It's because there's too much biology going on in the wrong place because this bacteria is trying to have a party in the wound. Now, in the pathway that is ischemic dominant, there is severely reduced blood flow. So the tissue cannot survive. Remember, we need our oxygen through the blood flow. Oxygen is our healing currency. So the tissue might present as dry and necrotic, can progress to actual gangrene. If it's wet gangrene, that's infection. If it's dry gangrene, it's stable. No matter what, you're going to need vascular. Okay, but what are the hallmarks? Pale, dusky tissue. Minimal exudate is usually when it is a dry. Okay, wet gangrene, infection. Okay, and then also there's going to be delayed or absent healing. The wound doesn't want to fight; it just wants to fade away. Now, when we have the mixed etiology, the ischemia as well as the infection, this is one of the most dangerous kind because it's infection and ischemia together. There is poor immune delivery, there is rapid, massively rapid tissue destruction, and this is where things can escalate super fast. Sepsis, limb loss, and this is where the wound don't just worsen, it actually unravels. It just wants to take all the healthy tissue with it. It's misery likes company, right? So at this diversion point, our job as wound care providers, or healthcare clinicians, is not just to treat the wound, it's to identify the dominant driver, who's in the driving seat of this wound. Is it an infection? Is it ischemia? Or is it both? And the wrong treatment at this stage can accelerate the failure of the wound. That is why it's good to identify and use the right mechanisms and but also diagnostic options to figure out what is the dominant driver of this diabetic foot ulcer. So everybody knows Wagner, but also a lot of people know University of Texas classification. I like University of Texas as well because it has a ischemic and infected component to it. So remember, with the University of Texas, grades are by grade and stage, okay? So they have depth and complication. So for University of Texas, grade 0 is pre-ulcerative, right? Or post if it's actually fully healed, right? 1 is superficial, 2 is to tendon or capsule, and 3 is to bone or joint. Stages for University of Texas, right? Because you're gonna have a grade as well as a letter. So A is clean. It's clean wound, right? B means infected. C means ischemic. D means infected as well as ischemia, the mixed etiology. So let's say it is the wound is a University of Texas grade 2C. That means it's a deep wound, right? 2 is tendon, right, or capsule, and C means ischemic. So it's a grade 2. It means deep and ischemic. If it's a grade 3D, right, 3 means it's bone or joint, right, or both. 3D, D means infected and ischemic. So if it's grade 3D, that means it's bone infection as well as ischemia. And this patient is at a high amputation risk. So what are other forensic clues when it comes to our wound bed? Location, location, location. Just like that song by Khaled says, send your location, right? I love that song. But location tells you the mechanical causes. So plantar forefoot, right? Pressure from gait mechanics. And then also, like we said, with a plantar forefoot wound after a TMA, right? And they still have that. That tells you or what they did in surgery. They told you that tells you pretty much they didn't do the adjunctive procedure of a TAL. The patient still has Aquinas, right? And has a lot of forefoot pressure on that area, and that's why, okay? Like you are able it's very interesting how a wound literally talks for itself. If it's a heel, it's usually immobility, pressure bound wounds on the medial aspect of the foot, we often think of overpronation or structural deformities, okay? Lateral, we think of friction or as well deformity, but also think of supination, okay? And then the tips of our toes, you got to think about intrinsic minus foot, clawing, neuropathic imbalance, okay? A lot of patients who have neuropathy, they end up getting hammer toes because of the intrinsic minus foot, okay? And also possible shoe friction, okay? And then if you add this vascularity overlay on it with a wound being on the distal aspects of it, it could be because of worse perfusion. Now, our callus edges can tell us also a lot about the chronicity of a diabetic foot ulcer. Thick surrounding callus, that usually tells us that there's a long-standing pressure there. Soft, irregular edges means there is a acute breakdown, so there's something else going on right now. And then undermining edges, there's shear forces involved, okay? So calluses, like I keep on saying, calluses are not harmless. They're pressure history markers, okay? Now, the color of the tissue. The color of our tissue tells us a lot about the vascular status of the tissue. We always want a bright red, beefy, right? Granulation tissue. Bright red means viable granulation tissue. Pale or gray means ischemia. Black means necrosis or eschar. And dusky purple means there's venous congestion involved or early infarction. So, our color is telling us a lot about the circulation of the tissue. So, tissue color plus equals vascular status plus biology. So when it's nice, healthy, and red, granulate tissue, what we want, good perfusion, active healing, there is capillary growth. Yellow with like slough, that means there's dead cells, there's fibrin present. It is right now in the inflammatory phase, and there's most likely delayed healing. When it's black and necrotic, that's usually consistent with tissue death, severe ischemia, often linked with peripheral arterial disease. But also, you have to think about the exudate because people could have necrotizing fasciitis. Okay, a lot of people confuse those two. Pale or white usually means poor perfusion or maceration. Maceration means there's too much moisture in it. That would make me think, oh, we need to increase the frequency of those dressing changes. We might need a different type of wound dressing, something like a hydrofiber, something, depending on the type of wound. Okay. And our exudate tells us also our infection behavior. So the serious exudate, right, that shows like low bioburden, but also early phase. Purulent drainage. That means that there's definitely active infection. Purulents are just the dead soldiers that were trying to fight out the infection, and that's them, okay? Foul odor. Foul odor usually is consistent with anaerobic bacteria or necrotic tissue. And then thick viscous drainage, a biofilm presence. And now they're just deep diving into biofilm research right now. But also the pathophysiology behind the color is if the oxygen delivery is low, that means that the tissue is dying, and that would be consistent with black. Okay, if we see it, that means oxygen delivery is bad. Inflammation, right? The fibrin builds up. The tissue is usually yellow. That also shows that the inflammation is high. And if it's red, nice and red, we want angiogenesis. And now the exudate, what our fluid means, because our exudate is our fluid from the wound, and it's not random. It's what's happening in the wound. So the serious, like I said, serious is clear. So like I said, it's an early stage, usually has low protein in it and mild inflammation. Sanguinous is bloody. I love me some sanguinous, but capillary damage or trauma, unfortunately. Seropurulence, okay? There's infection developing. It's serious, a little watery, but it's getting a little viscous because there is some infection in there. Purulence, it could be thick, green, yellow. That means active infection, high bacterial load. And, for the pathophysiology, the inflammation is high, that increases the vascular permeability, the proteins and cells are leaking out, and an infection, the neutrophils and bacteria, they create the purulent drainage. So when we're looking, we have to put all of this together. So when we look at a wound, we should be asking, how long has this been forming? What forces are creating it? Is perfusion adequate? Is infection present? And where is this on our wound timeline? So also another thing we have to address is the depth of the wound. The depth tells us the time. Okay. Superficial breakdown means it's a recent breakdown. Exposed tendon, delayed presentation, and deep one too. Bone exposure, chronic progression or neglect, unfortunately. Okay. So depth is time made visible in a wound. So think of a diabetic foot ulcer like a crime scene. You should put this on Netflix. So we got to think, what was the primary insult? Was it pressure? Was it trauma? Was it ischemia? Was it infection? Then you have to think of the sequence of events. Did this infection come first or did this infection come last? Did this ischemia trigger the necrosis or follow the infection? Was there evidence of repeated injury, like multiple callus form layers, a recurrent breakdown in the same exact location? That's why you should always ask the patient, have you had an ulcer before? Or did you have a callus here before? Oh, I used to go to the pedicurist all the time to get a callus in the same exact area. Scarred margins, that's a good indicator as well. Was there delayed discovery? So was the patient unaware due to neuropathy? Was there lack of foot inspections, daily foot inspections that the patient should have been doing? Did the patient miss the warning signs? Did a physician miss the warning signs? Because a wound never lies. I don't like a liar. That's one thing about me. Gabby doesn't like liars, okay? If anybody knows me well enough, that is one of my irks, okay? My biggest irk is a liar. And that's maybe why I love wounds so much because they don't lie. It just speaks the biology instead of words, okay? So, what are some of the most important forensic questions we need to ask? Okay, not how do we treat it, but why did this wound survive this long? to reach this stage, right? We have to ask, why did this wound survive long enough to reach this stage? Because there are many case scenarios of why this happened, why it's presenting this long, okay? A small lesion should have healed. A callus should have been offloaded. An early infection should have been contained. So the real investigation is, where did the prevention fail? Where did the detection fail? Where did the intervention fail? And this is how we understand, amputations, because like we said, amputations aren't just sudden events. These are missed opportunities accumulating over time. Next, one of our most important forensics discovery when it comes to modern wound care is biofilm. Biofilm is the bacteria embedded in the protective matrix, right? It's resistant to antibiotics, it's resistant to immune response, it's has cyclic flare-ups, right? And then forensically, our biofilms explain chronic non-healing wounds, recurrence after successful antibiotics, smoldering infection with minimal signs. And you would see this if there is persistent slough, recurrent odor, and delayed healing despite the treatment. You're likely seeing a biofilm driven wound environment in this diabetic ulcer. So, what are some forensic red flags of neglect or system failure? So, some wounds, like I said, tells us more than biology. They show us the system breakdown. So, if there's no offloading present, where's your shoe? Repeated ER visits without a wound plan. Antibiotics given without debridement. No vascular assessment done. I told you that's one of my biggest irks as well. When I hear a patient who's had diabetes more than a year, even the people will have it for 10 years and they don't know what I'm talking about when it comes to vascular. And I'm like confused by that. But you're on diabetic medication. You had a physician prescribe this to you on a routine basis. Diabetic medication to, you know, do glycemic control. And they never talk to you about vascular. Why? It's not Diabetes is not just about your blood sugar. It's about vascular, vascular, vascular. Okay? How do we stay alive with our heart? Through vascular. Okay? Patient vascular and podiatry. Okay? Patients are unaware of the wound duration. Okay? These are not clinical issues. These are care pathway failures. You have to remember that. Because that's like me going to somebody who's like, okay, like, let's say my skirt rips or whatever. I'm not well versed in it. I'm not gonna go on YouTube, but I would expect the person I'm going to know how to fix it, know what stitch to use, know what fabric to use to fix it, all this jazz. But us as clinicians, that's what we're supposed to do. And when our patients are well versed in it, that's our fault. That's our failure in the system because we're supposed to patient education was the biggest things. One of the biggest things when it comes to helping prevent amputations, not fear mongering, but education. Okay. The more you know, right? So, how do us as clinicians become wound detectives, become wound Sherlocks? Okay. Good wound care is not just treatment, it's investigation as well as intervention. So, we have to do serial photography. I always tell patients to do that. Debridement as a diagnostic exposure, that's why you have to debride, right? But nobody's asking you to cause a wound unnecessary. Please don't. And I think that speaks for itself. ABI, TBI testing for vascular mapping, no matter what, vascular assessment. Referral to vascular and follow up, okay? Make sure the patient sees the vascular within a week, okay? And I mean, vascular usually teaches us like emergent, routine, urgent, things like that, right? You'll know how urgent the patient needs to see vascular. Okay? Probe the bone test if there's most likely osteomyelitis. And then, we have to remember that there is a cultural difference between the places we go geographically. Okay? So our mindset should be there shouldn't be just what drugs should be used, like let's say it's infected, but what is happening here? When did it happen? So a diabetic foot ulcer is not just a wound. It That's why I tell people it's so fascinating. Diabetic foot ulcers are one of the most fascinating things in the world, in my opinion. Okay. It says so much. It tells us so much. It speaks for itself. And it's a timeline under pressure. It's a record of perfusion. It it's a recorder of your body. Okay. The only way the body's able to move even forward or get anywhere is through your feet. Okay, a history of missed signals, and a map of biological breakdown. And when you learn to read it properly, read the wound properly, you stop seeing the chaos and you actually see the logic. written in the tissue. I wouldn't say I get excited when I see a very complex wound, but it's just like you just gotta use your forensic mind to figure it out, and you know exactly what needs to be done. And honestly, I always say you'll be so surprised how well a wound thrives when you remove all the blocking barriers. It's the body again that heals itself. But once you remove all the blockages, like let's say it's infection, what happened if it's pressure, all this jazz, you'd be surprised how quickly and beautifully the wound closes. So the real power of, diabetic foot forensic is once you understand what the wound is trying to say, you can predict what it will do next. And that's where the whole healing journey actually begins. This is Diabetic Foot Files. I hope everybody's having a great Sunday. I should be on the boat right now. Sorry, cuz. But I will be there next time. And this is Dr. G. And take care of your feet because they take care of you.